Can you see my slides now?
Yeah, clear and loud.
Oh, brilliant. Okay, thank you very much, guys. It is a real pleasure to join you. I was planning to be there in person, but unfortunately couldn't make it. So here are my conflicts, which I work with everyone, so not really. I'll focus on Barrett's and squamous as the topic is about esophageal neoplasia. But in Barrett's, the biggest problem is we have a biopsy-driven protocol. When we take all the biopsies, we are biopsying less than 1% of Barrett's. So it's not that we're missing 40% of Barrett's neoplasia. And even worse, that we don't follow the protocol. So I think things have to change. One of the biggest problems with gastroscopy is people don't pay attention to things like this. If your esophagus is covered by mucus, saliva, bubbles, you are going to miss neoplasia. So we did this study a while ago where we randomized patient to a drink with N-acetylcysteine and simethicone versus water versus nothing. And what we saw was the mucosal visibility dramatically improves if you take a drink just before your gastroscopy. And I think that that is a standard in my unit and increasingly in most units in UK and should become a standard procedure throughout the world before a gastroscopy. Where to look for Barrett's neoplasia? There's a lot of data that it is generally between 1 to 6 o'clock. So this is the sector on the right side that you need to focus on. And that if you don't look anywhere else, it's okay. If you look on just this sector between 1 to 6 o'clock, you'll pick up 80% of the neoplasia. Technology is there. There's a lot of development in endoscope and technology which can help. This is the latest generation Olympus gastroscope with TXI showing you a lesion there in the Barrett's and look at the resolution of the scope. And when you switch on to NBI, you can see the vessel pattern right in the middle. It's disrupted, pit pattern is disrupted, and that clear marker of early cancer within Barrett's. The Teak and his group have published a very simple classification looking at mucosal and vessel pattern, which can help you use NBI to its best potential when you evaluate Barrett's with NBI. We published on this classification called Blink using BLI, and I don't call it a classification. I call this as a way of assessing Barrett's. Start looking at color, and if you see focal darkness like this, that is an alert sign. Then at the pits, and what you're looking is irregularity or crowding of the pits. They are a lot more here, or loss of pits. And then finally, the vessel pattern, and you can see the vessels are dilated, they are irregular. And again, there's a difference between this normal on the left side and the neoplasia on the right side. You got tumor vessels. So this is all the marker of neoplasia. So I think this system can help you assess and look for neoplasia when it is not obvious. But the easiest way to detect neoplasia in Barrett's is acetic acid, and I've spent last 12 years using and publishing on acetic acid, and the best way is to use this predict classification, which we published in Gut recently, and all you're looking is loss of aceto whitening. You see everything went white, and how its loss is aceto whitening and went red. This is a marker of neoplasia. And then you can look into surface pattern, whether it's abnormal, which means the crowding or loss of pits. And you can see clearly that the pits are lost on the right side. This has a very high sensitivity if you use this simple classification, and it can even help you characterize the nature of pathology. So if you lose your aceto whitening within 30 seconds, that's a cancer. If it is high-grade dysplasia, it takes about a minute to lose. But if you haven't lost your aceto whitening for more than a minute, then don't worry about it. That's a normal Barrett's. In my opinion, that doesn't even need taking a biopsy. Thus, acetic acid is one of those technologies which meets ASG's PV criteria as the negative predictive value is 98.6%. So it is one of the easiest and best way to look for Barrett's neoplasia. You see how this large area of high grade dysplasia around this nodule becomes visible only after when you use acetic acid. Before that, it wasn't visible. So it's very important if you're going to do resection, this can be extremely important to help you in marking, because otherwise you would just remove this nodule and leave this high grade dysplasia behind. So what is the future? Well, future is AI. And it can't be AI on its own. It is a combination of human plus AI. And we've been doing a lot of work on that. This is a device that we developed called Wise Vision in collaboration with a Japanese company called NEC. You can see how smart it is. That as soon as it detects a neoplasia, you get reverse L. Once it is sure, it delineates the neoplasia for you. Uh, and identifies exactly where it is. So this can help the endoscopist doing surveillance to take the right biopsy, or if you're doing resection, it can help you delineate the margins of the lesion. This is the early data that we published in GIE last year, showing a sensitivity of around 95% for detection of neoplasia. The most interesting thing is here, when you use AI on its own, the sensitivity of detection is around 94%. But if you use endoscopies on their own, it's only 63 to 64%. This is remarkable, and it is not unusual because we have seen this in real time that endoscopists miss 20 to 30% of neoplasia when they're doing Barrett surveillance. What is the treatment protocol? Well, for a long time, we've been following a very simple protocol that if you have a flat 2A, 2B lesion, then you can resect it with EMR because the risk of cancer is very low. But if you have a nodule or a 2C lesion, there has to be ESD or en bloc excision. And since then, this has been published by AGA. They recommend a similar way of choosing EMR versus ESD. And more recently, in our latest ESG guidelines on ESD, we replicated the same protocol, saying that if it is a lesion less than 2 centimeter or flat with no features of SM invasion, EMR band ligation is a good technique. Otherwise, we should be resecting en bloc with ESD. But this is a small area, as I described, a lot less than 2 centimeter. This can be very easily and very flat, no risk of cancer, but this can be easily resected using a bending device. This one is the Boston's EMR device that you can use and resect. But invariably, after resection, Barrett's has to be ablated. And now we have 5 different kinds of ablation catheter which can ablate the entire Barrett. So this is our 360-degree RFA ablation balloon using the modern protocol where it ablates the entire Barrett's about 3.5 centimeter, and you keep going until you ablate the entire Barrett's. And the results are very impressive. You might be aware of this New England paper which changed our treatment protocol because the ablation of flat Barrett's and Barrett's neoplasia with RFA is very effective. And now this is the way we manage. Everyone gets the neoplasia resected either by EMR or ESD, and rest of the Barrett's get ablated. These are the kind of lesions that you would not resect with EMR. This is an obvious lesion with a cancer. This is assessment of the depth of invasion in Barrett's can be very, very tricky. And I find that even using EUS to differentiate a T1A from T1B and a T1B from a early T2 can be extremely challenging. So it requires a lot of experience in selecting what lesions is safe to remove by ESD and what are not safe, because the consequence of having a perforation in esophagus can be disastrous. So you have to be very, very careful. But these certainly cannot be resected by EMR. This is where we would use ESD to achieve an en bloc excision. As you can see here, the entire lesion has been isolated, and then final stroke to take it off in an en bloc fashion. and we pin it and send it to the pathology to get a really good histology to help manage the patient. This is the largest Barrett's resection series with ESD that we published a little while ago, showing the safety and efficacy of Barrett's of ESD in Barrett's, because people worry a lot about complications related to ESD in Barrett's, but it is very safe in experienced hands. There are lots of other smaller series. They're all showing the same, that ESD for Barrett's resection is safe and effective. I think it's all about patient selection and the skill set of the endoscopist. So what is curative resection in Barrett's? I would ask you to look at the ESG guidelines, where we suggest that high-grade dysplasia and intramucosal cancer, if they don't have lymphovascular invasion and well differentiate, are certainly completely curative. If it's SM1, increasingly we consider as curative, but we do carefully follow them up. Also remember, the definition of SM1 is 500 micron below the muscularis mucosa in Barrett's. Once you become efficient in doing ESD, then you can push the boundaries. On the left side, this is a patient with T3 cancer, not fit for endoscopic resection or surgery, underwent radiotherapy. The whole cancer shrunk, and there was a residual cancer left behind, which you can see is so tough but can be resected by ESD. And on the right side, it's a post-esophagectomy recurrence of a cancer following esophagectomy, and the cancer is on the anastomosis. But again, once you develop enough expertise, these kind of cancers can also be resected by salvage ESD. I wouldn't recommend you to go home and do, but it is just to show that it is possible to do that in expert hands. Uh, Increasingly, we are seeing very large segments of Barrett's with multifocal neoplasia like this. Look, everywhere there is a neoplasia. So in these situations, we would perform a circumferential ESD and resect the entire Barrett's. Now, with that will come the consequence of developing stricture. It's almost 100% risk of developing stricture following a circumferential ESD like this. So there are various ways of preventing, and there is a multinational study going on right now using steroid and purostat in combination, and which has shown some promising results, but there's still no certain way of preventing strictures. These patients will develop stricture. We can minimize the number of refractory strictures by various therapies, but you cannot completely prevent it. What about squamous? I think Lugol is the best way. This is on white light. The squamous neoplasia is almost invisible. You enhance it, and now you can see there is a subtle redness and loss of vessel pattern. And you put Lugol, now even a blind person can see that there is a squamous neoplasia, because there's a yellow Lugol voiding area where the neoplasia is. Hopefully, this video can illustrate to you how subtle this squamous neoplasia can be. So easy to miss. If your esophagus is not clean, there is no chance you will spot an area like this. It's very subtle, just a subtle redness, a subtle loss of vessel pattern. You need to focus on that. Use your enhancements, use your Lugol, and you will certainly see there's a big area of neoplasia here. Look at this. And it's so easy to miss if your esophagus is not clean, if you're not paying attention, if your patient is retching and coughing and spluttering, no chance you will find this. That's why we have about 10 to 20% miss rate of these kind of cancers. You can use NBI, looking at various IPCL patterns to characterize the depth of invasion. As the cancer gets deeper, these IPCLs get tortuous, dilated, develop bizarre shapes, and they finally disappear when it becomes very invasive. I wouldn't recommend you go through Innovay's classification anymore, because now we have this simple JGS classification, which classifies into type B1, B2, and B3, which corresponds to different depths of invasion. Here you can see examples of how, as the dysplasia progresses, the IPCL getting worse and worse. And saying a video which shows you how subtle squamous neoplasia can be on white light. 99% of my colleagues whom I've shown this video were not able to see any abnormality in this squamous esophagus. But once you put NBI and evaluate it carefully, you will find a large area of neoplasia within this squamous lined esophagus. As you switch to NBI, you can see the IPCL is changing. This is all abnormal IPCL. See, it becomes even worse here. And you fill water and use NBI, it gives you added magnification. That's the borderline, that's normal IPCL there, I'm showing you. And as we pull back from here, you will see the boundary, the abnormal IPCL, and you stain with squamous, and there's a huge circumferential squamous neoplasia. Very, very easy to miss, but this is where we need to diagnose to make a difference to the life of these patients. And
Prof.
again,
Dari,
yeah, can make a difference. You can see
Professor.
looks quite sensitive in detecting neoplasia.
Prof. Bandari, can you hear me?
Oh, yes.
Yeah, your time is up kindly, so you need to wrap up if you don't
Uh,
mind. Thank
uh,
you.
okay, let me show you the guideline section. You see the let's sum it up here that if it is high grade or M1, M2, that is curative. If it's M3 or SM1, in the Western setting, we still consider as curative, but very carefully follow that up. But anything more than SM1 is non-curative. So to conclude, uh, most important thing is detection, and I've shown you all the techniques that you can use for detection. Then resection for Barrett's is in combination with ablation, but for squamous is purely about en bloc excision. Thank you very much.